So thank you very much, and thank you for organizing this terrific conference. We are very happy to be here. And let's start with a brief overview of our talk. So in this talk, we are going to assess the roles of non-epistemic factor in the making of epidemiological models of COVID-19. In the first part of the talk, we're going to see how that due to COVID-19 is actually registered. And this is important in itself because, as you know, mortality data that are obtained by looking at that certificate are part of the daily information that we receive from media and institution, and they influence our approach to the current pandemic. But mortality data are also pivotal in order to in the building of the epidemiological models of the current pandemic. To be clear, saying that non-epistemic factors, as we're going to see, play a key role in determining what counts as a death due to COVID-19 and in realizing the epidemiological model of the pandemic, we are not meant to say that these data and models are somehow unreliable, useless, or flawed. Okay, so let's start with a focus to the definition of a death due to COVID-19. In order to establish if a death is a death due to COVID-19, we have to look to death certificates. And that certificate have been standardized by WHO, and WHO also has issued some rules for classifying COVID-19 as the underlying cause of death. That is, as the disease or injury that initiated the sequence of morbid events that led directly to death. So a few words on how death certificates are structured. As I said, the structure of a death certificate has been standardized by the WHO. And apart from small differences from country to country, the current format of a death certificate is similar all over the world. And a death certificate contains two main parts. So let's gonna see them. In the first part, the physician that filled the death certificate have to indicate the exact sequence of diseases or condition that led to the death. And so in the case of, the first condition is the so-called immediate or precipitating cause. And then the physician has to indicate all the other conditions that cause the first one up to the so-called underlying cause of death, which is, let's say, the real cause of death. So in the first part is the most important, and here an example that is related to COVID-19. So in this case, COVID-19, a confirmed case of COVID-19 is registered as the underlying cause of death because it causes pneumonia, which causes acute respiratory distress syndrome, which directly led to death. So in the second part of the death certificate, the physician has to indicate all those conditions that are believed to have increased the risk or the severity of the underlying cause of death. But they are not part of the causal chain that directly led to death. So they are kind of aggravating factors. So they can be some kind of pre-existing chronic conditions, or in the case of COVID-19, they can be conditions that cause a reduction in lung capacity, for instance. So in the previous example, if COVID-19 is the underlying cause of death, in the second part of the death certificate, we can find something like diabetes, coronary artery disease, or asthma. Okay, so the problem when the physicians have to fill that certificate is that the underlying cause of death must be unique. And it's quite obvious because identifying a single underlying cause of death is, of course, fundamental for epidemiological and statistical purpose. So we cannot have 2 or 3 cause of deaths. But at the same time, it is increasingly frequent that death occurs in the presence of different disease or condition. And this poses a problem of selection. And this is a kind of problematic for a physician that have to register, have to decide about the underlying cause of death. So let's consider the example we have briefly seen before. So in the left part of the slide, we have COVID-19 as the underlying cause of death, and for instance, coronary artery disease as an aggravating factor. But it is possible that sometimes coronary artery disease can be considered the underlying cause of death, and COVID-19 just an aggravating factor. So sometimes we are faced with a situation like this, and this poses a selection problem. So how to decide that COVID-19 is the underlying cause of death and coronary artery disease is just an aggravating factor, or vice versa, that coronary artery disease is the underlying cause of death and COVID-19 just an aggravating factor? So of course, the first thing to look at is biomedical evidence. And so according to the WHO rules, we have, of course, to look at the pathogenetic mechanism that emerge from biomedical research and are certified by scientific consensus. But sometimes this is not enough, and 2 possible alternative causes of death are still present. And so according to WHO rules, when we decided about the underlying cause of death, we have to take into consideration some public health goals. And more precisely, the selection of the underlying cause of death must be carried out with a view to preventing premature deaths, and thus to hindering the precipitating cause from acting. So this means that the choice of the underlying cause of death must be made not only on the basis of biomedical evidence, but also with the primary objective of prevention and treatment in mind. So to say the underlying cause of death must be identified according to the WHO rules with the disease or condition that can be better manipulated in order to realize the most effective goals for public health. So let's consider the example that we have seen before, and let's assume that in a certain situation, COVID-19 and the coronary artery disease both led to death. So how to decide which is the underlying cause of death? We must consider COVID-19 as the underlying cause of death if preventing COVID-19 is easier than preventing coronary artery disease, or if both conditions are equally possible to prevent. COVID-19 again must be identified as the underlying cause of death if blocking COVID-19 is more effective in avoiding premature deaths than blocking coronary artery disease. And an important point that must be stressed is that according to the WHO's rule, COVID-19 can be correctly considered the underlying cause of death even in the case of a mere suspicion. So even in the case that there is no swab or other test that confirm the presence of COVID-19. So to wrap up the discussion up to now, the underlying COVID-19 the underlying cause of death must be selected with the primary objectives of prevention and treatment in mind. But prevention and treatment, this means that prevention and treatment are positively evaluated. So this means that non-epistemic factors play a key role in the selection of COVID-19 as the underlying cause of death. So it's important to stress that WHO intends to consider COVID-19 as the underlying cause of death in the case in which it has caused, or it is supposed to have caused or contributed to cause the death of a subject. So the case of COVID-19 is somehow similar to another important case, which is much discussed in the literature that we can just mention here, that is the case of HIV/AIDS. Because in the case of COVID-19, overwhelming public health reason, that is non-epistemic factors, make it possible to indicate COVID-19 as the underlying cause of death, even in the case of a mere suspicion, and so in the presence of other and independent causal chains that led to that. So I will stop here and I leave the floor to Elisabetta for the second part.
Okay, thank you. So yes, our main point was done, and now what we're going to do is to link this point on the concept of death due to COVID-19 to some points about epidemiological models. So so we are connecting our talk with the previous ones that we've just heard.
Elisabetta, we're seeing your slides, but they're not in slideshow view.
Oh, really?
I don't know
Sorry?
if that's okay for you or not. We can see them as, yeah.
You can, yeah, yes, it's better now.
That's better, yeah.
Okay, thanks. Okay, determining what counts as death due to COVID-19 is relevant to understand and to assess epidemiological models. And we've seen that there are many models around, for example, the Imperial College model, the Institute for Health Metrics and Evaluation model, the London School of Hygiene and Tropical Medicine model, Yang-Gu model. And now I'm not saying anything new from to all of you that because these are points that you've maybe seen already in the literature. Most of them have the structure of SEIR models because they represent individuals in a population as moving through 4 states: susceptible to the disease, exposed, infected, and removed, meaning deceased or recovered. So a few words about how these models work. As the number of infected is always unknown because not everyone is tested or can be tested, most of these models just fit confirmed deaths and calculate back how many infections would have been likely to produce such a result. Also, this model, we have to take into account that they build on data about the virus and they build on data about the population. These are familiar points. And for example, age, mobility, health status, and family structure. And of course, the accuracy and the predictive success of these models to some extent depend on the quality of the data they are fed with. But this is not the point when we are pursuing here. Here we are, sorry, now I'm not, yes. Here we are focusing on the idea that models depend on parameters and definitions on parameters. And these are not data, but these are more conceptual tools that epidemiologists can pick and choose in order to manage data with a view to the explanation and prediction of the phenomenon. And so let's focus on death-related parameters. So these models can choose between a variety of these death-related parameters. For example, there's the infection fatality ratio or rate, and it estimates the proportion of deaths among all infected individuals. And the IFR depends both on testing, of course, and also on prior biological knowledge of the mechanisms of virus transmission. And this parameter has the definition of death due to COVID as an ingredient. So if you believe what we've been saying in the first part of the talk, it inherits the value ladenness of the concept of death due to COVID. Another parameter that can be that can occur in these models is case fatality ratio. This is the proportion of deaths among identified confirmed cases. So it's a little bit more, well, less speculative to say. But nevertheless, it is exposed to specific biases or systematic errors. For example, we read on a fact sheet published in last August by WHO that if deaths are more likely to be reported than recoveries, the CFR will be overestimated. But of course, it can also possible that the reverse occurs. So, and that will be leading to underestimation. But case fatality ratio anyway, just like IFR, it has a definition of death due to COVID built in as an ingredient, and therefore it inherits the value ladenness that we've been talking before. Sorry. Oh, yeah. Also about case fatality ratio, we know about COVID-19 that the risk of death of this disease is very unevenly distributed among groups stratified by age, socioeconomic status, unfortunately, and also ethnicity. And so if we choose an undifferentiated SFR parameter, we'll end up to masking such differences in the predictions of model. And why? Whereas if we choose stratified SFR measures, it is likely that these differences become apparent. So the general point here is just that such a choice of parameters always involves social and ethical considerations, as models are intended to guide institutional interventions. Another death-related parameter that can be involved in predictive models is the number of overall excessive deaths in a population. And if we choose a measure of overall excessive deaths versus deaths due to COVID-19 only, this can show how the virus impacts on the overall health of the population, for example, by limiting the quality and the access to treatments for other pathologies, such as cancers, cardiovascular diseases, and so on. So if one chooses this measure, one implicitly assumes that actions aimed at preventing such an impact are worth taking. Death parameters in general. Well, using death parameters implies focusing on the goal of preserving life in general and treating all deaths equally. Here, non-epistemic factors kick in again. This choice, of course, should ideally be qualified further when it comes to choosing the goals of healthcare strategies. So it can be brought into the discussion another kind of measure of scale, which is the potential years of life lost. This is a measure of the time a person would have lived had he or she not died prematurely. For example, this is often used in cancer and other chronic diseases. But choosing PYLL as a parameter means that, of course, not all deaths are treated equally, as greater weight is given to deaths at a younger age and a lower weight is crudely put to deaths at an older age. So death-related values and life years lost come apart when mortality is unevenly distributed on ages and disproportionately affect the elderly. To sum up, governments' mitigation strategies and interventions can be affected by the choice of death-related or years lost-related parameters in a predictive model. For example, of course, closing schools may have a decreasing effect on death-related values, but an increasing effect on life years lost in the long term, even though arguably effects of interventions on PYYL are more difficult to quantify and predict, and as they locate in the very distant future. However, just not to consider PYLL is itself sort of a choice that is not made on purely factual grounds. It's not we could say is not purely a scientific choice. So to sum up, we just try to unpack the various roles that non-epistemic factors might have in the making of epidemiological models of COVID-19. And first, we did that by a zoom in on the definition of death due to COVID-19, which we based on an analysis of the WHO regulations. And then we tried to apply it in the case of different parameters that can be incorporated into predictive epidemiological models. So we're not going to say that mortality, we didn't mean to say that mortality data and epidemiological models are flawed, unreliable, useless, or non-purely scientific. So maybe the initial motivation for this paper and this talk was, well, a little bit to contrast the idea that on the one hand, there are data and numbers, and on the other hand, there were choices. And we try to say, well, actually numbers are choices to some extent. So non-epistemic factors play an important and unavoidable role in all the scientific enterprise, we think. And this is widely recognized and well documented, and shouldn't be that it makes us thinking that science is not reliable or objective. But yes, the biggest distinction between facts and non-epistemic values is that the first ones could just be acknowledged by non-epistemic values can be discussed, and therefore is always interesting to keep them to some extent separate. Thank you for your attention.